Good evening and welcome to our latest webinar in a series related to past forced adoption policies and practices. This is number 8 in our series of webinars, so hopefully you've joined us previously or you've been able to see the previous webinars. Tonight we've got another case study and this is about working with complex clients, so looking at some of the complex issues that we're facing, and as always we have a panel who I'll introduce in a moment, and time for question and answer. So I'm looking forward to the next hour and a quarter of a lot of interesting conversation. I'm Lynn O'Grady and I'm a National Project Manager here at the Australian Psychological Society, and I've been managing the Forced Adoption Project for 18 months or so now. Before we do begin, I would like to acknowledge the traditional custodians of the land and pay respect to elders past, present and future. They hold the memories, traditions, culture and hopes of Aboriginal and Torres Strait Islander Australians. And we're based here in Melbourne, or some of us are here in the office at the APS, and the Wurundjeri people of the Kulin Nation are the custodians of the lands where we're actually sitting this evening. People might be aware of the training that was also developed, so these webinars sit within the context of a bigger project, which is some e-learning courses that are available to health professionals, and we know that some of you will have been watching some of these, but if you haven't seen them yet and haven't had a chance, we would encourage you to have a look at them and to really get registered now, because they're free for a period of time that won't be forever. So we would encourage you to have a look at those. You can see there's the topics, so really looking at the experiences of past forced adoption policies and practices, looking at the clinical framework that you might be using in your work, and then a particular focus on mothers, fathers, adopted people, and then a session also, a module on search, contact and reunion process. So really covering off a whole lot of the different aspects of this work and the various people who are affected, but having a framework to work within. Clinician self-care, of course, is really important in this work and is a topic that's covered across all of those modules. So we do encourage you to really have a look at that and to make the most of that opportunity while it's there. We'd also like to acknowledge people who are affected by past forced adoption policies and practices, and really mindful of this as an ongoing impact for people. And the reason that this was developed was really to try and provide more support than what was there before, and make sure that professionals who are seeing and working with people who have these impacts are able to do their best that they can in understanding the needs. But the contribution of people in this training is also really important in terms of contributing to our understanding of that, to share that with you. Tonight's topic, as I said, is about complex clients, so comorbidity within the context of past forced adoption policies and practices, working with complex clients. You can see there the learning outcomes that we're hoping to achieve, and you would have had a look at these already in the information that's been forwarded to you, but just a reminder. So looking at the biopsychosocial model of health, so thinking holistically about clients, the core principles of best practice in supporting people's complex mental health needs within the context of forced adoption, and identifying ways to integrate these core principles into day-to-day interactions with clients and as part of your overarching service provision. So the panel that we have with us tonight, 2 professors, which is pretty special. So Professor Daryl Higgins is a psychologist, and Daryl has been part of this project from the very start. And if you have participated in some previous webinars or you have been doing the e-learning, you will have seen Daryl participating in that previously. And Morris Eisenbrook is the other professor who's going to be joining us, and Morris is a psychiatrist, and Morris has also been on a previous webinar, and both Morris and Daryl were part of the expert advisory group who were part of the group moving this project forward. And Morris, we can see you, but we can't see you completely, so we need you to jump in front of the camera so that you can say hello to people. So welcome to both of you, and thank you very much for joining us. Morris, I'll start with you. You've had a very busy day and we appreciate your time, but what particular interest do you have with working with forced adoption, people who are affected by forced adoption in this area? What is it about it that you find interesting?
Well, as a child psychiatrist, I've been interested all my professional life in questions of attachment and dysregulation that occur from early experiences in life, and certainly in clinical work I've seen plenty of examples of the consequences of adoption, fostering and other disruptions in attachment, and at the other end, working with parents who are depressed, who are suffering psychiatric disorders as a consequence of disruptions, have seen the other end of it. I'm also an anthropologist, and having worked in Southeast Asia, in other countries, I've also seen a different type of adoption in which disruption of families has occurred for other reasons than the kind we see in Australia, and that's brought me to another perspective. So I think clinically and from a research point of view, it's a very critical area that's been under-investigated around the world and certainly in Australia.
Right. Okay, thank you. So I think you've given us a taste of what we're going to hear from you in terms of very broad understanding and bringing a very deep understanding to the work. So thank you for that, Morris. And of course, Daryl, you've been part of this work for a long time, but you've recently moved jobs. So where does that leave you in terms of working in this space or further research? Is it sort of you moving on from this and having reflections back now, or are you still looking at keeping it as part of your interest area?
Yeah, Lynn, look, I've been working on this, as you know, when I was previously at the Australian Institute of Family Studies, and I'm now the Director of the Institute of Child Protection Studies at Australian Catholic University. And look, both roles allowed me to have a research focus across a whole range of areas, but I was delighted to have had the opportunity to work on this topic, having come from a background in research around topics like child abuse and neglect, and around other aspects of family functioning, which of course leads one to looking at trauma and its impact. So I was very fortunate to be able to have sort of 5 or 6 years where I had a number of projects that were related to conducting research and looking at the service models and service needs, and then more recently working with you guys in terms of advising on and developing the e-training courses. And so while I don't have any current projects at ACU directly on this topic, I still am often referring to the research and using it as examples of both the important way in which we need to make sure that our service delivery responses are based on the evidence, but also the analogies between the experiences of people affected by forced adoption and so many other areas of public life that we can apply them to.
Great, thank you. So you can see already from Daryl's conversation as well that we've really got a range of perspectives here. So we've got the research and the system perspective, and we've got the more practice, day-to-day practical experience that Morris is going to bring. So I'm really looking forward to having some really good insights from the presentations and then really good discussion afterwards as well. So thank you both again. We're really looking forward to this. Before we do begin the presentations, though, we do find it's really helpful just to go through some ground rules and just remind people, I guess, of the process and how we're working together. So I like to think about webinars as if we're in one big room, we just can't see each other. But thinking about the comments and the general chat is available for everybody to see. So for our particular webinar, people can see the chat. So if you're commenting in there and asking questions, which we do want you to do, just be mindful that everyone can see that. So treating it as a face-to-face professional development event is what we would like you to do. So use the general chat for that. Use the technical support box if you've got some technical issues, and we'll have Redback, who are a great support and really running these webinars from a technical point of view, will act very quickly and get you some support with that. What else do I need to say? If you find the chat distracting, and some people do, they say that they can't kind of listen to the presentations and the discussion and keep an eye on the chat. So if you find that, you can use that little arrow at the top of the chat boxes and close that down. So you can shut that down completely, or you can close it down for a short time and then come back to it and come in and out of it. So that's up to you. We're also really mindful when we have these sessions that people sometimes join us having not heard about forced adoption policies and practices before. So for some people joining us tonight, we've got over 70 people now, which is fabulous. We know that for them, this might be the first time they're actually hearing about this. And so that can take a bit to get your head around and to be really thinking about the processes and things that were in place or weren't in place or weren't followed. So it can be quite difficult to hear about that. For other people, they've been working in this space for a really long time and very familiar with that. And then there are others, again, who might have their own personal experiences, might be working in the field because they've been affected in some way by forced adoption experiences within their lives or within their families. families' lives. So very mindful of all of that, and we're very mindful also of the webinar. The idea of it is that you can see us, but we can't see you. So we really want to just alert you to the risk of distress that might happen, and remind you, I guess, around self-care and what sorts of things you can do to look after yourself during the session. At the end, we will ask you for some feedback. There's a very short exit survey at the end that we just need you to hold on to for a moment when it pops up at the end of the webinar. That's really important. These webinars and the whole project has been funded by the Federal Government Department of Health, and we do report to them on the outcomes of the webinars, and your feedback is incorporated and sent through to the department. So it's really important that we report on that, and we have used that feedback over the course of this series of webinars to inform our work and to make sure that we are working using this format as best as we can. And one of the things we do each time that we run a webinar is just to go through, spend a few minutes really showing a video, which is one of the introductory videos from the e-learning modules. And even if you've seen this before, hopefully you'll still find it enjoyable, but we are aware that each time we do have people who haven't joined us before, so it's really important that we get into this kind of space, I guess, and start to think about what did happen and the context in which the case study that we're going to be talking about occurred, so that we're all on the same page and starting to think about that. So we'll have a look at that video and then we'll start moving into the presentation. Thanks, Luke.
And had their babies removed, all for the want of a wedding ring. Forced adoption was a practice shaped by societal mores of the 1940s, but it continued right up until the 80s. Over the past few years, there's been a chorus of formal apologies as each state sought forgiveness for its role. Today, the federal government added its voice.
Today, this Parliament, on behalf of the Australian people, takes responsibility and apologises for the policies and practices that forced the separation of mothers from their babies, which created a lifelong legacy of pain and suffering. We acknowledge the profound effects of these policies and practices on fathers, and we recognise the hurt these actions cause to brothers and sisters, grandparents, partners and extended family members. We deplore the shameful practices that denied you, the mothers, your fundamental rights and responsibilities to love and care for your children. You were not legally or socially acknowledged as their mothers, and you were yourselves deprived of care and support. We apologise.
In Australia from the mid-1940s through to the early 1980s, state and federal governments, churches, charities and hospitals, medical staff and bureaucrats were involved in the forcible removal of newborn babies from their mothers. Unmarried and often young, these mothers were viewed as unfit to parent their own children. Their babies were placed into adoptive families, usually with couples unable to have children of their own. This confidential, irrevocable process severed all links between a child and its parents and was known as closed adoption. The effects of forced adoptions on the mothers, the fathers, the adopted people themselves and their families have been lifelong and in many cases intergenerational. Mothers' advocacy groups have since lobbied for recognition and acknowledgement of the harm these policies and practices have caused. Initially, 2 state government inquiries into past adoption practices in Australia were held, and in October 2010, Western Australia became the first state to offer an apology to people affected by forced adoption. In February 2012, the Senate Community Affairs Reference Committee tabled a groundbreaking report into the Australian government's involvement in past forced adoption practices. This report followed an 18-month inquiry in which hundreds of people gave evidence. Following the report, all the remaining state and territory parliaments, apart from the Northern Territory, offered their own apologies. And in March 2013, then Prime Minister Julia Gillard offered an apology on behalf of the federal government to all people affected by the policies and practices of forced adoption. The Australian government has since allocated funding to support the development of guidelines and training materials for health professionals working with people affected by forced adoption policies and practices. This e-learning program has been created as part of this response.
Okay, so hopefully that's given people a bit of a sense of what it is we're talking about and the experiences that sort of led to this whole project happening. Of course, we're really mindful that this is ongoing work, and this project has been part of further work, I guess, that is ongoing. And we can see there Sharon is alerting us to adoptee advocacy groups for logging for recognition of harm related to any adoption. So it's obviously part of a much bigger picture. And I guess our goal tonight is to sort of focus on the case study that we have so that we can really tease that out. But we're also mindful that a lot of the sort of suggestions that you're going to hear might apply to people who are affected by adoptions or by other experiences of trauma. So just wanting to put that context there, but also just to, I guess, help us to contain our discussion, our expectations, to remind us that it's the case study and the particular focus that we want to keep. So just a reminder again about the case study. Hopefully you have had a chance to read through this, but just a bit of a prompt to get us into that space as well, and then we're going to hear from Daryl. So the case study is a fictional case, but certainly drawing on experiences that we've heard about and read about. So Mary, a 68-year-old woman, presents for a psychiatric assessment after being referred by a clinical psychologist, currently staying for mood-related issues, substance abuse and suicide risk. Mary had a child when she was 16 years of age as a result of being raped. Parents put the baby up for adoption, and Mary now remembers a little of that time in her life and prefers, in fact, not to think about it. Mary does have a second child, Paige, with whom she's had a very strained relationship, as Mary has been drinking heavily. Paige has children of her own and doesn't like that Mary's often drunk and angry around them. So she's putting some restrictions around seeing her. Mary separated from Paige's father not long after Paige was born and has no friends or contact with her community. During the assessment session, Mary makes comments such as, "It would be better for everyone if I was dead." So let's move over to you now, Daryl, and hear your reflections, your thoughts about what's happening with Mary.
Thanks, Lynn. And look, what we see here in this case description of Mary is not at all uncommon when we look at the research. And as I said at the beginning, I was involved with a number of research studies where these kind of things are important. And you can see on the list there that I have on the screen some of the typical kind of clinical symptoms that we see that are very common in relation to forced adoption. So mood disorder, substance abuse that is often takes the form of self-medication, so that kind of responding to trauma but trying to numb the feelings and get a sense of getting away, if you like, from the reality of life. We see elements of suicide risk and also dissociation in the clinical picture. And of course, a range of different strains in the relationships that she has, or absence of relationships or breakdown of those relationships, and also very limited friendships outside of her immediate family. So as I said, Mary is not at all uncommon, and the research that I was privileged to have led at the Institute of Family Studies drew on 505 Marys, for want of a better word, that we heard from those mothers about their experiences. And while not all had the kind of clinical presentation and the kind of negative outcomes that we see here in Mary, that was certainly the experience of many. They typically had mental health and well-being problems that we assessed using the survey in that study that showed there was a higher than average likelihood of these mothers suffering from a mental health disorder. Around 1/3 of the mothers showed a likelihood of having a severe mental health disorder. They rated their quality of life as low, and certainly we see that very strongly with Mary, to the point of suicidal ideation. And often we use terms like post-traumatic stress disorder to best sort of encapsulate the grouping of symptoms that we see. And there's some interesting additional features with Mary's case description here, that there's also references to sexual assault and rape. And again, that's not uncommon, that we had many people respond to our national survey saying that that was their experience too, whether it was directly the cause of the pregnancy, or in fact even subsequent to that, where the kind of medical involvement relating to the birth process and afterwards, they describe the interventions in terms of a sexual assault. And you can see on the webinar slide there the reference to some of that research. So PTSD, as I said, is one of those phrases that we often use to describe this group of symptoms. But another phrase is complex trauma. So it's a useful concept for understanding these kind of presentations, because sometimes when you might have someone like Mary presenting to a psychologist or a psychiatrist who rely on their DSM criteria, they don't necessarily meet the diagnostic criteria for PTSD. And that there's a number of other characteristics that are in the associated features that tend to more typically define these kind of cases. And that's the case not only in relation to issues such as past adoption experiences and separation between parents and children, but does often get seen in relation to other examples of extended interpersonal trauma. And I mentioned at the beginning my work in research relating to child abuse and neglect, and also adult sexual assault. And both of those broad fields often have this issue where there's extended interpersonal trauma that you're not able to kind of escape from because it's an ever-present part of you. The reminders are always there. And of course the rape compounding that issue of trauma for Mary. So Mary is just one example of a complex picture. And it's, while I've talked about the commonalities with many of the mothers who responded to our surveys, we also see some of these features in other groups affected by adoption. They might be fathers or adults who were the children from whom parents were separated through the adoption process. These same kind of clinical features can emerge there as well. And so the lessons that we learned from that research study was that those groups can also be significantly affected and demonstrate PTSD-like symptoms. But is traditional, so that then suggests PTSD might be an important way of thinking about this. So the kinds of therapeutic approaches that I'm sure many of the people online tonight would be familiar with, are they the right way of approaching it? And of course, cognitive behavioural therapy is one of those. But from the research that I did looking at what those who are affected by forced adoption, so mothers, fathers, adults, adult adoptees, and others, what their reflections were that when the typical kind of therapeutic response that was offered was CBT, they often described their frustration in the inadequacy of that. And why is that? Well, one of the things that came out very strongly in that scoping study about the ways in which people affected wanted to have their needs better met was the primacy of the issue of having a therapeutic relationship with somebody who acknowledges their experience and who understands it and gets it, but also where they're able to have some opportunities for restitution. And there's a particularly strong theme around engaging in services and the complexity of that when those service providers themselves may have had a past involvement in forced adoption. So for those of you who are professionals working in the context of an agency, I'd encourage you to have a think about some of the issues that are raised in the e-learning modules around the importance of healing and what your organisation can do from a sort of a justice perspective, but also the importance of positive identity as well is another one of the things that they talked about. So how do we go about treating complex trauma, regardless of the issue of forced adoption. Lynn mentioned at the beginning the importance of the biopsychosocial kind of model, and obviously we look for any underlying biological conditions, psychological and other mental health conditions, but also substance misuse and psychiatric conditions such as depression, anxiety and PTSD, but also personality disorders. And so does focusing individually or even in sequence those kind of issues, does that work? Well, the messages from people who have a past adoption experience is very clear. The research shows that what they desire and what works best is an integrated approach where the kind of trauma survivors are able to have the multiple conditions acknowledged and dealt with in a holistic way, but importantly coordinated and integrated together by somebody who understands and supports. And additionally, there's also fairly significant agreement around the positive benefits for many people in group work, particularly where it's therapist facilitated or led, but where there are opportunities for sharing that information with other people who have a very similar experience. So just to kind of recap on some of the key messages from that research, it's about validation of their experiences, and we heard many, many times from mothers and from others who felt as though they had to be their own experts and advising their mental health professionals about the reality of their experiences, and even worse, dealing with denial and active disregard for the truth of the experiences that they were recounting, often because it just was not known about and didn't fit with what mental health professionals saw as being likely or possible. So, events such as today's webinar, the training, the e-training that the APS is offering, I think goes a long way towards raising broad community awareness, but specifically the knowledge of health professionals such as yourselves about the events that surrounded the period of closed adoption, and importantly the range of experiences that those who were affected may have encountered. But it is important also to recognise that practitioners do need specialist therapeutic skills to address those ongoing effects around trauma or identity issues, negative self-concept and relationships that relate specifically to the adoption experience. And I'm delighted to be able to hand over now to a much more experienced professional than I who'll be able to talk about some of those practice issues.
Thanks very much, Daryl. Very comprehensive and a lot of information that you've got through in a really short time. So thank you very much for that. There might be questions that people have, or there might be pieces of information that Daryl touched on that you might think, I'd like to find out some more about that. So use the chat box to ask some questions of Daryl. We'll bring you back and get a bit more information on some of that if you would like to. And I know that Daryl is keen to hear from Morris, as we were talking about how good it is when you're in the research space to actually have somebody who's actually in that really very practical clinical space to be really sharing that with us. So really also interested to hear what Morris has to say. And again, please use the chat box if Morris is saying something you want him to elaborate on, or there's a question that you'd like him to answer. Please use that, and so that we can really tailor it to what it is that you're wanting to hear about. So over to you now, Morris.
So now we're starting off with exactly where Daryl left it. That is to say, what does the psychiatrist have to offer the multidisciplinary team? And in this case, the psychologist, after having seen Mary for a while, has referred her to the psychiatrist. Let's see what he's looking for, what she's looking for. The question is, can the psychiatrist identify clinical risk, issues of self-care, comorbidity, which is really the focus of this evening? And so just before we go into anything else, we can think again about what Daryl has listed. Depression, somatization. So the psychiatrist will be wanting to know whether the patient has mild, moderate or significant depression, and whether it's indeed simply a depression as a response to the situation, or whether there's something such as a bipolar illness that might require a slightly different intervention, and so the family history will need to be checked. Another note would be the suicide risk. And we know the hotspot here where Mary says, it would be better for everyone if I was dead. So we would look to see, and any GP or psychologist or health professional should do this, taking a careful history, looking for previous attempts, previous suicidal ideation, which is a key indicator of further such thoughts. It's quite interesting in this context because the fantasy in the case of Mary might well be, and you might have to dig this out, is there an idea that the child that she relinquished, that she gave up, somehow needs to be refound? And one way to find the child in a way is to die and be reunited with the child in another place. That history of suicide and the presentation of suicide might call for the CAT team or some acute intervention. And I won't go through all the other psychiatric conditions that Dale has mentioned, such as alcoholism, anxiety, personality disorder, each of which requires its own response. But I want to change gear completely. This approach I've just indicated, with these lists of psychiatric problems, is absolutely not enough. Here is an opportunity really to turn an adverse situation around. If we could seize this and see how Mary, who's had a lifelong history of problems over decades, before and since the loss of her child at the age of 16, could have some therapeutic intervention that is comprehensive and could turn her life around for the rest of her life. This will involve a collaboration with a referring psychologist, and I want to go into this now, presenting this as a hub with 7 spokes. So rather than a kind of a wish list or a list of things to do, I'm suggesting it as spokes because where you start and how you align this depends on your rapport with Mary. You might start with a history, but you might start with the relationship with Mary. It depends on what's going on then and there. So these are now spokes. First, and this is not in order, let's think about working through the scars after the forced adoption experience, an experience that some call relinquishing, but we're calling it forced adoption. And the phrase here, it felt like it was night all the time. There was no one in her corner. There was no one helping Mary through her life. She had her parents who had, in a sense, taken the decision for her, and then she was in a relationship that didn't have any, that was not sustained, and she then disconnected from expressing emotion. She described a poverty of feeling. She didn't describe anger, sadness, anxiety. It was kind of shut down. Did she renegotiate her identity? We don't know, but we need to find out. And did she feel that the child had gone, but somehow was still there? Something called boundary ambiguity. It's rather like what happens when, say, a soldier goes to war and is missing in action. Are they dead? Are they alive? Are they there? Do you let them go? So is the adopted child psychologically present after all these years? The second spoke, which is corollary to this, is opening up the history. And bearing in mind that a third of parents, such as Mary, have significant problems early afterwards. 71% in one study have coloured subsequent marital interaction problem. In other words, they transfer the problem to intimate relations in adult life. Mary had a relationship with a partner, Asia's parents, that broke down very quickly. 4/5 of these have an impact on subsequent parenting, and here's where Paige comes in. So people like Mary may have extreme fears of losing their child, the subsequent child, being overprotective or setting high standards, or not allowing their children to be independent. And we need to come back and look at Paige in a couple of minutes. Our third spoke is working through the disenfranchised grief. What's disenfranchised grief? It's when the loss is not recognized by others in the society or is played down. So Mary and people like her are denied the right to grief. There's also an assumption in applying willy-nilly grief theory that there is an end point, that surely after 1 year or 5 years or 10 years it's enough and Mary should get on with her life. But there is no end point. So what are the consequences? The intensification of anger and sadness, but it can't be expressed. The diminution of social support. Mary is totally alone. The self-disenfranchisement, when Mary doesn't even recognize that her own grief is a legitimate thing for her to feel herself. And the feeding over of that grief into the death of a significant other. Spouse, not in this case because there isn't one, but perhaps the parent. And we haven't found out in this history, and it should be explored, when did the parent die, when did the other parent die, what was the significance of that? Because bear in mind that Mary was ambivalent, parents forced the decision, who knows how she felt about that. When you have complex grief, level of grief, it's more difficult. So in short, on this spoke, we're viewing the loss in the grief model as a positive thing because we can normalize Mary's reactions rather than seeing them as pathological. The next spoke comes from these. Think about Mary and the cascade of trauma that she suffered. Think about Daryl's concept of complex trauma. A rape at 16. What were her pre-16 conditions of life? What was going on for her? An unwanted pregnancy, a traumatic birth, and so on and so on. So it's the cascade that makes the complexity of the trauma important, and it should be clearly explored in the clinical encounter. In this encounter, the fifth spoke is to look at the triggers. What was brewing in her life? The lack of support, the suppression of the feelings, things we've talked about already. And then the triggers. In particular, the reminders like anniversaries. And it's essential in clinical encounters to ask the person about the dates. When did your mother die? When did your father die? What was the day of the week? Can you remember the day or the date that you lost the child? That you had the adoption take place? Or what were the illnesses and deaths of other significant others in the family? And these can be the key triggers which allow the unlocking of her emotions. And this may be what makes her weep or connect with what's been locked up. The next spoke is to work through the relationships. So it's the relationships going all the way back to the family of origin. So were there problems before and during the adoption? Because this is a betrayal for her of safety, of trust, an induction into shame, and an enforcement of secrecy, because in those days many people wouldn't say about this. And the loss of the relationship then with the child. And then that flows on to the conflict with subsequent children, such as Paige. So Paige is a substitute for the lost child. What are the implications then? And then we see here how Paige is threatening to deprive Mary of contact with the next generation. Is this, in a sense, for her, an experience of a recapitulation? In other words, she's lost the first child. She may lose Paige because of the rejection by Paige, and now she may even lose Paige's children. And it's very important then to show Mary this process, to let her talk about this, so she can get insight into how to stop it, and how not to use her alcoholism as in the service of gaining the terrible end from the beginning. Now, there's one more point in talking about relationships, because right now we're talking between you, the clinician, and then Mary, the client. If she's had this disruption in relationships, how might it come through in her relationship with you or with me? And so it's important to be sensitive to that and notice signs that in her relationship with a psychologist or a psychiatrist or the other mental health professionals, there is a kind of testing of limits, testing of relationships, and it might even be helpful to show her that at the time and let her see the link between her history of mistrust and the way she's handling this experience. And now we come to the final spoke, which is how to enlarge the radius. This is prevention. So if Paige has suffered something like, just imagine what Paige went through in the first years of her life after this history. Maybe she re-experienced trauma herself. Maybe she had insecure attachments. We can't presume it, but we have to check. And so that's where the complex trauma is transmitted to the next generation. And one particular form of that is called developmental trauma disorder, or DTD for short. And as Daryl said, PTSD is not seen in children, and the conditions here are not necessarily those for PTSD, but we look for DDTD, which starts from the earliest moments of the child's life. I'm talking about subsequent children of the mother, like Mary, and can lead to anger, fear, self-loathing, a reenactment of the trauma, an anticipation of the loss, a sense of lack of safety, because the thing that Mary is doing now presumably was there, even more so, in the first couple of years after the loss of the first child, whose name we don't even know. So, in short, the hub of these 7 spokes is to come to trauma-informed care. As I said at the beginning, to put psychiatry into a unifying framework, collaborating with a referring psychologist, it's not handing the case to the psychiatrist. It's how to work in complement. So the CBT might be needed from time to time. The group therapy should be introduced if it's appropriate, and the individual psychotherapy to work through these spokes and the collaboration with specialist services like drug and alcohol, etc., where required. And so essentially what we do here is creating a therapeutic environment that does not inadvertently re-traumatize Mary. The principles are awareness of trauma, the emphasis on trust and safety, and the opportunities for Mary to rebuild control over the life where she's lost control since she was 16 or earlier. Essentially a strengths-based approach to Mary.
Fantastic. Thank you, Morris. And again, an enormous amount of information in a very short amount of time. So thank you for putting that together. And I really love the way you pulled together the spokes and hub model. I think that's a really nice way for us to try and pull out the complexity of this and pull out the different aspects which sort of overlap but are really quite distinct areas, and making some decisions around where do we begin and where do we move to, I guess, is part of that work. So really comprehensive and really helpful. I'm still looking for some questions. So if people have got some questions, please put them into the comments box there. But in the meantime, we do have enough to keep us going, but we would like to hear any that you have as well. So we've had some discussion around this, and Daryl, you sent through some questions for Morris that you were really interested in hearing some more about. And one of those was around how do we achieve the positive outcomes in terms of the focus. Have you got that question handy that you could ask Morris about?
I seem to have lost my questions. I had it just on my screen 1 second ago, and now it's disappeared.
I've got it here if you want me to read it out.
Yeah, thank you.
All right, you can find the others while I'm doing that. So this is a question for you, Morris. How much of what is important in achieving positive outcomes for Mary about the choice of a particular technique or therapeutic modality versus how much is it the importance of validating Mary's experience of forced adoption and trauma and building the positive therapeutic relationship with her?
They're both important, as Cecilia and Charybdis. I don't adhere to any particular theoretical or psychiatric mode of intervention, and that's why I put up the hubs and the spokes. None of that will work, none of it, whether it's giving drugs or doing CBT or group work, if there's no relationship. And because Mary's fundamental problem is about relationships, that's where, from the very first minute of the consultation, that's my focus. Now, how it plays out after that depends upon the person and what she or he is amenable to. Some people show an obvious need and a hunger to be with people. Others show a need to feel that they are safe and they're being given medication.
Okay. And I guess one of the things we talked about the other day when we were planning for this was this person has been referred, Mary's been referred to you, the psychiatrist, by the clinical psychologist. And I guess what circumstances might you be thinking someone might make that decision, and why might they consult with you? And then what's your response to that, I guess?
Again, every case is different, but presumably the patient, client has shown that there are greater levels of complexity than met the eye when treatment was instituted by the psychologist. Perhaps CBT was introduced straight away, or perhaps some other form of treatment, and after 10 sessions, say, under the mental health plan, and it's not surprising, because how could 50 years of agony and suffering be alleviated significantly after barely 10 sessions? So more is needed. And maybe the other complex problems were not revealed. Maybe because of Mary's style, she didn't show her full hand of suffering symptoms. The alcoholism may have been concealed, even though Mary's daughter talked about it. But was Mary's daughter actually seen by the psychologist? Was there any other information from the referring practitioner to the psychologist? So I think it just requires time to unravel. And I do believe that it's very important that the psychologist doesn't hand the case over, but rather that the psychologist and psychiatrist immediately collaborate, and that the client knows that, so that there are more options, and that there is a greater network of trust already. After all, just think, you go to a psychologist, talk for 10 sessions, when you have such a fragile sense of trust, and then the psychologist says, thank you, goodbye, sends you to another person. That's counter-therapeutic.
Cheryl, did you find the other, because there was another question underneath that one about Paige.
That's right. Yeah, look, we've been talking a little bit about her, and certainly she was mentioned in the case study. I'm just wondering, Morris, your kind of clinical reflections on how important you think she is in the picture, both in terms of addressing Mary's therapeutic needs, but also in her own right, in terms of how forced adoption might have, in fact, impacted on Paige and what her needs might be. And I suspect that they might be somewhat interrelated with Mary's needs.
So, part one. What is Paige in her representation to Mary? We don't quite know how old she is, but let's say she's 20-something. So that means that more than half, well, a lot of Mary's life has been wrapped up in what she sees Paige. Is Paige a substitute, as I mentioned before, for the lost child? Is Paige a representation of the father who left or was left? And how does she feel ambivalence about that? And so I think it's important that for Mary's sake, that is unpacked. Now, turn it around for Paige. I've also hinted at the importance of breaking the cycle. After all, we might trivialize this question of forced adoption because we might say, well, it happened so many years ago, it doesn't happen anymore, we're much more savvy about these mental health issues. But the problem is, unless we actually see the knock-on effect, the intergenerational effect, not only on Paige, but on Paige's children, then the stain of the forced adoption will continue for generations to come. And we're trying to deal with that. Now, possible that Paige, in her own way, because of the complexity of this, is feeding into Mary's problems also, and that needs to be investigated. It may well be that Paige should come to the party, that she should be seen, that we should explore the possibility that she also should have some kind of therapeutic intervention in her own right, or even that Mary, Paige, and the kids might be involved in some systemic family therapy. If that's
so how much of that would you be wanting to deal with, Morris, as a psychiatrist versus the concept you mentioned before around, working in concert with other mental health professionals? And where does Paige fit within that kind of collaboration?
Yes, psychiatrists are as diverse as psychologists. And so there are some psychiatrists who don't do this kind of work and who essentially prescribe psychotropic and other anxiolytic medication. So a referral needs to be done carefully so that the psychiatrist getting it is capable of providing the rapport I mentioned and also providing the range of therapies they need to hear in collaboration with psychologists or psychotherapists, others, family therapists for that matter. I think that it's better for the psychiatrist to know the limitations, and it's necessary to get a third person involved in the family, in the therapeutic chain, if that's needed. But it's essential that the canvas of work that needs to be done is actually recognized. And if the psychologist feels that the psychiatrist hasn't picked it up,
really complex case, I guess, needs a complex response with multidisciplinary team, I guess is what we're hearing. We've got a question from Nikki that picks up on that. So Nikki asks us, when working in collaboration then, is it important to have complementing treatment styles, or is it acceptable to use two vastly different styles to address separate issues, or purely addressing this from an idiographic standpoint of the client?
I think that it is important to have complementing treatment styles. But again, what is essential is the relationship on which the treatment styles is founded. And I think using vastly different styles to address separate issues, to me, is atomistic. It really breaks those spokes apart. It doesn't really make sense to a person to say, on Monday you're going to have medication and on Tuesday you're going to have CBT. Whereas if you see the interplay between them, then the person can develop greater trust and a greater confidence that they're being treated as a whole person and not simply as the patient in bed 12 with an appendix and a gallbladder.
Yeah, look, I would add to that by just saying that what you said, Morris, I think really does complement what people in the research studies that I've been involved with have said that yes, the variety of styles is one issue, but what's more important is about having coordination and them being linked up. So having some express and explicit kind of acknowledgement of this is why we're putting these things together. This is how they fit together, and I'm involved because of X, and person Y is involved because of, what's the rationale. And that the frustration that people describe when they've had poor service experiences is because either there's been no coordination or no communication about that. So, I would encourage all of the participants in this webinar to be thinking about what are their strengths and how can they play to them, and where there are complementary but not contradictory elements to a therapeutic goal that need to be delivered in tandem with somebody else, that's clearly articulated. Of course, one of the issues is about making sure that everyone is still working from the same page in terms of their broad understanding of the trauma and its impact. I think it's counterproductive to recognise that somebody else might have some really great skills around a particular area if they still don't really come on board with that acknowledgement of the reality of the past experiences, some detailed knowledge of the nature of those events and how they play out, and to be able to adapt that into their therapeutic style.
Thanks, Joel. And very comprehensive answers, I think, that really do remind us again of the complexity of this. And I guess what springs to mind for me is the importance of supervision when working within these kind of complex situations. Where do I fit? What am I able to do? Because sometimes when it seems complex, we can underestimate our own abilities, but also not necessarily know where our scope is. So having good supervision is something that sounds like would be really helpful in this case. Sharon has reminded us about the adopted person, and Morris, you picked up on that the adopted person wasn't included in the case study particularly, and we didn't have a name for the adopted person. So why don't we spend a moment just maybe hypothesising what might be the sort of circumstances around that, and why the adopted person wasn't a focus for our case study. Who wants to go first with this one?
I'm happy to jump in if you like.
Okay. Sure.
One of the reasons why we might not know the name is because Mary, the fictional case study that we're basing this around, doesn't know the name of her son or daughter. In this case, I think it was a son. And that's the reality, that many people who were mothers were separated, at birth or very shortly afterwards. They were not given the opportunity to name their child, or even if they were, that was then not respected after the separation process. So Mary is the lived reality of many mothers from that period. So one of the challenges that people like Mary face, and also the adoptee face, is the choice of trying to find out about finding information about in the first place who their family member is, where they might be living, and then seeking out a process to potentially engage, so to make contact, share information, and potentially try and meet up and establish a relationship. Sometimes we use the word reunion, but of course it's it's a little bit of a loaded term. It implies that there was a union in the first place, and of course many people describe the absence of that opportunity to bond and unite with their child. So it's a complex issue, and again I'd mention the really great e-learning modules around that topic. But that's likely to be playing out not only for Mary in the way that we've described, but for the child from whom she was separated. And who knows what his life story has been. Maybe functioning very well, but also maybe experiencing very similar kinds of trauma around identity questions in terms of who am I, perhaps having the imagined Mary. He might not know her name is Mary, but having an imagined Mary and thinking, what's wrong with me? Why did she give me up? Thinking there was a whole level of agency that's absent from Mary's story, but for that individual thinking, what is it that that's wrong with me that would allow a mother to give me up?
May I come into this and just
sure.
Or I do, but I have a question for Darryl as well, which will pick up on something that I think Sharon, Roz and Nikki are asking about.
Yeah, okay.
Let me just come here to the case of the missing child. And it's interesting that just as the child is missing from the case study of Mary, the child is missing from our webinar. And now as the child has come, which is right. And so it actually reminds me sideways of a film which a French-Polish filmmaker made about Polish nuns' secret pregnancies after mass rape by Stalin's troops in 1945. It's a film called The Innocents, and I highly recommend it. You see how a group of nuns had to hide their forced pregnancies after rape and what was done with those infants after they were born. Think about that. But in this case, this missing child is ever present. And I think every time this Mary sees Paige, there's the child. It's an ambivalent child because it's a result of rape. She was 16. She was hardly emotionally competent to be a parent. And what is her mass fantasy? We don't know the name. We don't know if there was a name given. Once the confidence has been established in the relationship with Mary, I would ask her. I would say, when you imagine, do you ever think back to that moment that you lost your baby? Then right into it. Did you see the baby? Did you hold the baby? Did you touch the baby? Did you smell the baby? So it's going right to the beginning of that grieving process. And then to say, where is this baby in the world? Locate the baby in the world. And I don't think this is danger ground. I think as long as the patient is safely held, that's where one needs to eventually take this question. Patient is safely held, that's where one needs to eventually take this question, to make the baby real again. Mm. Now I wanted to ask Darryl a quick question which touches on epidemiology and evidence-based approaches.
Yep, right.
He has expertise. And I'm just wondering, if we look at the whole thing to avoid stereotyping, all mothers like this are going to be like that.
Mm.
See the complexion of the lie of the land across these 2,500 or more incidents. How many of them have conflicts?
Well, it's a really difficult question to answer, Morris, because we don't have true prevalence data. I can speak about the data from the self-reports that we had from those people who chose to respond to our surveys, where we see around about sort of 3/4 having very high levels of mental health disturbance that would meet clinical criteria for kind of trauma in that broader sense, not necessarily meeting all of the criteria for PTSD, but certainly showing the kinds of distress that's typical of people who have PTSD. And while it's not representative, the reality is that there is no way of being able to design a survey that is representative when you don't actually have a population base from which to sample. You know, if you're taking another area of research and you want to say, are teachers more likely than social workers to be distressed or have trauma, you know who the teachers are. So you can go to the teacher registration boards, you can say there are X thousand teachers, we want to sample them and we want to look at the rates and compare them to registered social workers, etc. So those kind of research questions are easy to deal with. This was such a complex issue and we didn't even know how many people we were dealing with. So having more than 1,500 people respond to our self-report surveys was really an amazing snapshot into the lives of people who were affected by forced adoption. And I've got to say it does actually match the kinds of issues that were raised in similar kind of, processes such as the Commonwealth inquiry into the role of the impact of forced adoption, where of course people had to go through a process of giving evidence to that inquiry, and many people did. And certainly my discussions with the various senators and others involved with that inquiry, and having read the report, I would say there's a strong degree of similarity between the experiences that they received evidence about and the responses to the survey that we conducted at the Institute of Family Studies.
Thank you. With going back to some basic things, Elizabeth has asked what led to forced adoption coming to an end. So I guess we're in this kind of space, aren't we, of still gathering information, still seeing the impact of it. And then there's another question a little bit further down from Roz about television shows like Love Child having an impact on people like Mary. So we're in this kind of space, and Sharon talking about the need for more research and really hearing the range of voices or other voices that perhaps haven't been heard so far. So any comments, Daryl? I guess you're the best one in terms of the end of that forced adoption, those processes.
Yes.
Start there.
Happy to talk about that. So in some ways it's an easy question to answer, and in other ways it's very difficult, because some people would argue, or at least raise the question, has it finished? The easy answer, I suppose, is that laws changed in so many different ways. So in Australia, the relevant laws are regulated at the state and territory level, and over a period of 15 years, the laws relating to adoption changed, and the period of closed adoption has ended, and now the only adoptions that can occur are what are called open adoptions, where there has to be rigorous processes around consent, but also there is no eradication of the identity, if you like, of the child and her or his relationship to the biological parent. However, in practice, the reality of that can be quite different and quite varied. So despite the fact that laws prevent the issue of completely forced or closed adoption, the capacity for open adoption is not always exercised fully. It takes a lot of support and engagement for adoptive parents to remain connected with one or both. In fact, if there is both parents on the picture, the parents who gave birth and were separated from their child via adoption, acknowledging nowadays that it does need to be willingly. However, of course, the definition of willing is difficult to ascertain when the life circumstances of a parent may be severely impacted by troubles like whether it be mental health issues or quite commonly drug and alcohol issues. Those are the typical things that would be seen in the child protection systems, where these things might lead to the question of should adoption occur. But it's very, very rare nowadays. So the number of adoptions to an unrelated person, so excluding where you might have an adoption within a family, a step-parent adopting, or where there's been a child has been orphaned and they're then adopted by another family member, that's sort of a separate issue and is more about the legalities of inheritance and so forth. That those issues really are still, in some ways, very much alive for people. But of course, there's a whole range of social mores that changed, and practical supports. Massive impact, I think, of the introduction of the pension, the single parent pension. So the financial supports that enabled mothers to be able to support children outside of wedlock, and of course massive social changes regarding the views of marriage in the first place and the role of children born outside of wedlock, the introduction of no-fault divorce, and the recognition of cohabitation relationships in Australia, massively changing attitudes, but also being a reflection of the attitudes that had already changed that led to those legislative and policy changes. So it's a bit of a chicken and egg situation, but we're certainly not in exactly the same place that we were when the height of these adoptions. And we know that around 1970-71 was when they were at their peak, with almost 10,000 adoptions occurring that year.
Yeah. Okay, thanks, Daryl. Anything, Morris, in terms of that question around Love Child? Do you kind of think that TV shows that pick up on these sort of topics, do they bring people to seek help? Do they have an impact? Any thoughts about that?
Never seen it. I can't comment.
Oh, okay. It's a TV show that's happening at the moment about this forced adoption experience. So I guess if you're thinking about any kind of dramatisation of a serious sort of event or situation, what impact that might have on people, whether or not it's a useful thing that raises issues and brings them into the therapy room, perhaps, rather than keeping it silent. Or is it unhelpful, I guess? Could be the other option with that. I'm looking at some of the discussions, and there's quite a bit of people talking to each other, which is always helpful, and answering some questions, and certainly some questions that people are finding really useful, the conversation that we've had. There was a question about the 10 Medicare sessions from Carol. Does anyone have ideas on what we can do when people come to us with 10 Medicare sessions, and that is all that is possible or affordable to them? So if Mary was at her 10 sessions, as Morris suggested she might be, what are the options? We're saying we need this comprehensive range of support, but how do people get that if it's not going to be funded by Medicare and they don't have their own financial means?
Somebody should be speaking here about the forced adoption support service for the state. I don't know if Daryl wants to.
Yes. Yeah, I was going to jump in with that. So thanks for the reminder. So while it's not explicitly a counselling or therapeutic service solely, the Australian government has, through the Department of Social Services, funded forced adoption support services right across the country, and they're able to help with a whole range of issues, particularly ones around finding out about family, the process of connection, identity, dealing with the birth and death, the records office, etc. But on top of that, they're often embedded within broader service delivery agencies. So in almost every state and territory, the forced adoption support services are run by Relationships Australia. And of course, Relationships Australia don't just do forced adoption work, they do a whole range of relationship and counselling and support services. And they can find ways of being able to coordinate and link in to better meet the ongoing support needs. They also have really great relationships with local self-help and support and advocacy groups, which can be an important part of the mix to complement the services provided by more clinically oriented professionals. And I should say too, in Queensland, where it's not run by Relationships Australia, it's run by Jigsaw. And they're exactly the same in terms of their networks with other groups and other providers. So as a mental health professional, I would encourage you to not think about just the limited number of sessions that you might be able to fund to offer, but how you can kind of progressively act as a bit of a broker and work with those other providers. But absolutely jump onto the Department of Social Services website and look up Forced Adoption Support Service. And certainly the guidelines, if you like, for those services really encourage the issue of networking. And I know we talked a little bit about collaboration before. Well, I was able to work on a document that outlines not only just the importance of collaboration, but how you actually go about building networks. And while it is oriented specifically towards the needs of those forced adoption support service providers, it is equally important for the other side, which is really all of the people participating in today's webinar, in order to understand how they can in turn link in with those forced adoption support service providers.
Yeah, great. Thank you, Daryl. And Margie has popped the phone number in, the Forced Adoption Support Service 1800 number in the chat box. And in the folder at the bottom right-hand corner, there's also a resource list which does have some further information about that and tells you where to make contact, as well as some other information that will be really useful. Our time is ticking away, as it always does when we get into these conversations, and often feels like we're just really getting into some of the really interesting discussion when we have to wind it up. So I guess the last minute comments will take away messages, because we have covered an awful lot of ground, and we can see just from the comments that are coming through and people sharing some of their own kind of thoughts and challenges and ongoing challenges, that there's a lot of undone work yet. There's clearly more work to be done, and we are part of the kind of progress that's being made, but there's still more work to be done, that's very clear. But sort of takeaway messages, given the complexity of cases like this, people going back into their office tomorrow thinking about what do I want to take from this. Morris, do you want to kick us off with just a few take-home key points for people?
Sure, I'll start with the individual clinical and I'll take something globally. I think, first of all, that it is possible, no matter what the constraints of the system, and no matter how limited you might feel, that you can have a significant effect on Mary and people like Mary if you've got the right approach to the situation, and it does not require rocket science. It requires basically a human connection. But I don't want to romanticize that. There are certain tiers and rungs that are needed to make that human connection work, and I think that in the presentation we've outlined those. At a global level, I just want to say that this situation with forced adoption will never end. Why? Because it's a paradigm of something that's going on globally around the world. The situation of children who have been produced in troubled circumstances, for example, of rape, troubled circumstances of war, civil war, and this is something that's in most low and middle income countries. A huge proportion of children who are being born are not that different than what we're talking about here. And even though the focus of our series that the APS has put together is strictly on forced adoption, not even adoption generally, I think there are lessons to be learned which can influence literally millions of children around the world.
Thank you, Morris. Thanks very much. Darryl? Okay.
Yeah, look, we've acknowledged the people who have experienced forced adoption, but I actually want to end on acknowledging each of the 81 people who are currently online. What I have learnt from this whole experience of being part of the journey of understanding the impacts and hearing from those affected about what they need in order to assist them in their recovery and moving on positively with their lives is people like you who share an interest in understanding their journey and are happy to walk alongside them. So I would want to just reinforce that all of you are taking great strides towards achieving what the research shows is needed, and that is knowledge about the events of the past. It is understanding and strategies to not only believe, but to be able to positively influence clients. And so I want to congratulate all 81 of you who've stuck in there with us for this hour and a bit, and for those who've made use of the broader e-learning resources, because that's really, I suppose, where we can have our greatest impact is by changing the attitudes and the skill set that we come with, and have confidence that that you have those capacities, because that's what people who are affected are really looking for.
Yeah, fantastic. Thank you, Darryl. Very, very affirming, and you, Morris, as well, bringing that bigger picture as well to put this in a broader context as well. We've talked a lot about the training, but I think it is really important, given that we have been talking about a whole lot of complex issues here, and people might be thinking, I need to know some more about this. I'm not sure that I know enough to do this work. So this is why that training was developed. You can see there's 3 different online courses. There's an 8-hour main course for health professionals. There's a 2-hour training for GPs, and there's an overview which hopefully some of you have done leading into tonight's webinar. And the other webinars are also available that we've done previously, and some of them had a focus on different aspects. So we would encourage you to continue tuning into this, continuing to learn, and continuing to gain your own skill set as well. If you do work through that 8-hour course, you can then have the opportunity to become part of a national support network. So at the end of that, we asked if you would be interested in having your name passed on to the Department of Social Services funded service providers, so Relationships Australia and Jigsaw in Queensland that we're talking about. So that's an option as well, because it is building that support network for clients. So we are at the end of our last webinar, so thank you very much to you, Darryl and Morris, for your participation and your input tonight and preparation that went into planning for this evening. Thank you very much for your great insights and the strengths and the positivity, I think, in what is obviously very difficult and challenging work for people and for people experiencing this. So thank you very much for joining us again. Thank you also to Redback and MHPN and to our people from APS moderating behind the scenes, fielding those conversations that have been happening and sharing some information so that people can link in and get some further information if they need it. So the last thing is the exit survey. So when we close, you'll see the survey pop up. So please do take a little bit of time to do that. It won't take very long at all. A certificate of attendance will be issued in a couple of weeks' time, and you will receive a notification that the webinar is available online. So thank you everyone for joining us this evening, and best wishes in this work. So I'll finish there and say good night and thank you.
Bye, everyone.